Well, hi, everybody. Welcome to GW Center for Integrative Medicine. We have a very special podcast for you today with our own Dr. Deirdre Orceyre, whom she and I have been working together for, gosh, I don't know what,
Didn't you
15
join in
years?
2008 or 2009?
I know, it's kind of scary to think.
Yeah, I know.
Um, Anyway, so let me introduce Dr. Orceyre before we jump into the topic. So, Dr. Orceyre graduated from National University of Natural Medicine, a leading institution in natural health, and of course, it's a naturopathic school. So she's had over 20 years of experience. She's been with GW Center for Integrative Medicine as the director of naturopathic medicine for, what is it, 18 years, 17?
Yeah, exactly.
Yeah, she also holds Masters in Science of Oriental Medicine and does acupuncture and a lot more. We'll see if we talk a little bit about that. And she's teaching. She's a part-time faculty at Georgetown CAM program, integrative medicine program there. And she and I have shared thousands of patients. So this is going to be a little different than how we do this. I don't consider Deirdre a guest. She's she's a co-director, so it's not really a guest. But anyway, so the topic today is cancer. Hard topic, difficult topic. And I kind of want to open us up with a little bit of introduction and basics, right? I mean, everybody knows what cancer is and the treatment is, but of course, we are in the business of integrative medicine and integrative cancer. So, Dr. Orceyre, define to us sort of this idea of naturopathic oncology and also the integrative oncology or integrative approaches to oncology.
Yeah, absolutely. Thank you. And thank you for having me on your uh, YouTube show.
Not
It's the right way to
your
say
YouTube, it's our YouTube.
it. Our YouTube. Yeah, so integrative as opposed to alternative is where I usually start with that. And then depending on the practitioner, it might be an MD or an ND, naturopathic doctor, or some other form of practitioner. But what we are here is that we are complementary or integrative as opposed to alternative. There are places that cancer patients can go that are alternative, where they may be clinics like in Mexico or China or Germany, where patients get treatments that are different than chemo, surgery, radiation, hormonal therapy, targeted therapies. But what we do is we work with patients who are under conventional care. So they're working with a medical oncologist, they're working with a surgeon, with a radiation oncologist, and we are trained to help those patients reduce side effects, which often allows them to tolerate their medical treatments better. And also, we do provide some complementary treatments that boost up the cancer fighting potential of everything they're doing. And so I'm trained to look for avoiding interactions between supplements and drugs. And I'm trained to, in the research where you can use certain diets or supplements to reduce side effects for patients, which is very real. And often oncologists, unfortunately, are not trained in these studies. So that's what I do, is complementary, and it's a whole field. There are a couple of professional organizations. The one that I am a part of is the Oncology Association of Naturopathic Physicians. There's also the Society for Integrative Oncology, which is more of the medical side that the MDs go to, and sometimes those two collaborate as well.
Mhm.
Yeah,
And we've been as a clinic involved a little bit in both.
yeah.
We had some projects collaborating with both organizations. We're going to talk about, when we get to talk about mistletoe, for example, we collaborated, Society of Integrative Oncology collaborated on this large John Hopkins mistletoe study with Channing Paller as a PI. And and Channing and I had worked for quite a number of years together, and we'll talk a little
Mhm.
bit about all that. So, we've been closely following both of these
Yeah.
organizations, and we really, I think, as center, trying to say this are our umbrella organizations because we are evidence based, and as you pointed out, we're not against or we're not alternative approach, right? We're a complementary approach. Yeah. So let's talk a little bit more about how we different from other places, right? I mean, you mentioned Mexico, China, Germany. I mean, there's a lot of clinics out there that people ask us, well, I don't want to do the standard of care. I perceive it as toxic. Can I go to one of those places to get cured? You've done this for a very long time. What have you seen? Have you, how would you position this question to people? Like when they're asking you, look, I want to go to Mexico. What do you tell them?
Well, I tell them that in my experience, the patients that I've seen who have the best outcomes are the ones who combine conventional treatment with what we do. And
Hmm.
often the oncologists agree. They're like, wow, you're doing better than our other patients. What are you doing? Keep doing it. You hear that a lot. But I do have patients that really, for whatever reason, they don't trust the conventional system or they have a different belief. And in those cases, um, I will tell them other clinics that I know of, and there's a couple of websites out there for like there's a reporter who investigates these different clinics, so they can look that up and find some reputable ones. Um, and I tell them, it's a very personal decision. I will not turn my patients away if they decline conventional treatment. I will help them as best I can, but in my experience, I see the best outcomes is when people combine conventional and what we do.
And we do have that occasionally, right? I mean, I probably say 90% of our patients are under standard oncological care with and us. But we do get some patients who sort of, they end up going completely alternative route and they still
Yeah.
want to work with us. And we would endorse that sometimes when the patients are in a very advanced form of disease and they failed multiple different standards of care, and they're at the point where all their care is basically completely experimental, and there's a lot of uncertainty. So I think in the cases like this, we're probably a little bit more open,
Mhm.
and not just more open. I mean, we're always open, but more supportive of looking for other things. So yeah, and there's always there also this recently all these questions come up about this repurposed drugs. I
Mm.
didn't tell you I'm going to ask you this, but I kind of have to, especially now that I'm hearing some political noise that new administrations wants this repurposed drugs to be fully engaged for cancer patients, and I can't tell you more because A, I don't know more politics, and B, I don't want to know the politics, more politics. So, but that noise seems to be real. They're gonna
Yeah.
be looking into some of this medications, ivermectin and the statins and mebendazole.
Antifungals, right, right. Mhm.
So, we don't really do a lot of this because there's really no science. There's really no strong evidence. There's no evidence whatsoever, actually, to be exact. It's a bunch of anecdotal stories and some claims and this and that and tiny, tiny preclinical trials mostly. Maybe there are a couple of small clinical trials. It's really not, I wouldn't consider, plus all these drugs actually have serious side effects. So, question to you. You get this asked. I know, like you get this, and then we have a conversation. You and I are like, oh my God, not again. But like, we have to deal with this, right? Because the
Yeah.
patients come to us and they say, look, what about this? So what do you tell them?
Yeah. Well, as you know, many of our patients are highly educated and they are doing their own research and they are looking in and not just like Facebook research, but actual PubMed research. They're looking at the studies and they come in and they say, well, I read this about, metformin is a good example. And so I don't want to disrespect that. I don't want to be like just dismissive.
Hmm.
And there is some evidence for these off-label drugs, and some of the evidence is stronger than others, and some of them there's preclinical evidence. So there's not at clinical trials, but there's really, there's some good preclinical evidence, although we know that that doesn't necessarily translate into human trials.
Right.
But the drug maybe has another benefit for the patient. Like maybe they have pre-diabetes, or maybe they have hypertension, and their cardiologist wants to put them on a statin anyway.
Right.
And so I weigh all of those different things. And if there are some medications that seem to be multifunctional, then sure, let's give it a try. And then I always have a timeline, like,
Mhm,
let's do a baseline and then let's monitor. And hopefully we can do it around the time of imaging or when they're checking a
mhm,
tumor marker, some way that they're monitoring the cancer. And then
mhm.
we do it for the 3 months and then see if there's any improvement. And if not, let's not waste our time and waste money. But I'm open to them. But again, like you said, I just don't think the research is totally
So,
there
so,
yet.
so,
And,
so here's a real question,
yeah.
and I'm putting you on a spot, but
Hmm.
but it has to be done, right?
Hmm.
You ever seen any real response to any of this? And let's not talk about metformin and statins because those are relatively harmless compared to a bunch of other stuff. But
Oh, yeah. So you're
here's the
talking
thing.
about the ivermectin.
I'm talking right. So I'm talking about ivermectin, mebendazole. I'm talking about some of this, more recent because metformin, you and I have been using for cancer patients for probably 10 plus years at this point.
Yeah.
Statins came
Hmm.
a bit later after that, but statins
Hmm.
also such a prevalent use that we don't really like. I
Yeah.
don't
And
have a problem.
antihistamines also have
Yeah,
some.
and antihistamines, right? So
Yeah.
those are a bit more kind of, they don't have the kind as much of controversy, not necessarily because the research is there, but because they're just perceived to be a bit more benign,
Yeah.
and it's easy to monitor for their side effect.
Yeah.
Talk about other medications. So have you ever seen anything real like that you can put your hat and say, oh wow, so there is that? Because
I've had patients who came to me already on them who had advanced metastatic disease, who I maybe monitored for like 6 months and then they kind of disappear, right? So they come in and they say, I've been doing ivermectin, I'm doing well, I'm stable, and they really believe in it.
Mm,
But I don't have anybody that I have monitored them for longer than a year that I'm like, wow, they're doing really well. And I think it's the ivermectin. I really don't. And I have to admit, it rubs me a little bit the wrong way because ivermectin is such a hyped drug. And there's so much talk about it's like being hidden and there's secret cure to cancer and things that I just absolutely know are not true.
right.
That really, it makes me angry because patients come in with a false belief and they think that it's going to do something for them that it doesn't.
Mhm,
And uh yeah, so I don't have, if I thought like, when I have patients doing vitamin C, mistletoe, and their oncologists are like, you're doing really well, keep doing whatever you're doing,
mhm.
that makes an impression. But I haven't had that experience with mistletoe. Sorry, I haven't had that
Right.
experience with
Yeah. Oh,
ivermectin.
I'm glad you brought this up because the
Yeah,
sea and mistletoe, we see this, oh my God, from
yeah,
oncologists. And I mean, we see these cases.
yeah,
We'll talk about that in detail, but we see this all the time. In
yeah,
fact, our whole packaged care, we see regular responses that are way out of ordinary. I wouldn't say, I mean, I hate the word cure because I don't know what that means, but with cancer, it's hard to put that term. But
right,
definitely seeing responses that are way better than average. I would just
yeah,
put it that way.
right,
But I'm with you. I have never seen or heard or witnessed any of my patients who came to me. And yes, okay, given we don't probably have a big volume of such patients. I mean, I don't know, we probably have double digits, maybe up to triple digits altogether after over the last 10, 15 years of patients who've been taking these medications. But I haven't really seen much like you to sort of put my head and say, well, this is real. So yeah.
yeah,
So okay, well, let's talk about a bit more about sort of how do we work at the clinic. So
yeah, good.
before I ask you more questions, what I thought of doing, I'm gonna share my screen and I'm just gonna walk everybody through some of our resources on our website, and so that you kind of fully understand how we do this. So this is Dr. Orceyre's page on the practice, so you can welcome. I'm sure that we will put the links to all of this, and then we have this treatment programs. And then you can find a cancer program here. Let's see where it is.
I don't see it.
Yeah, it has to be there. So we have a missile here. We have a mistletoe. Oh, there, mistletoe injection therapy for cancer. We have that, and I think we also have a under conditions. So we'll have a So we have a cancer
Oh, yeah.
here. And so basically, you all can come here, those of you who are listening, and check it out. We have a lot of details, sort of what it is. Dr. Orceyre just defined what oncology, integrative oncology is. Of course, she and I are, well, Dr. Orceyre really and Dr. Sodralso, though, two are naturopaths who are kind of doing most of the oncology, and then I sometimes help out. We do a lot of IV therapies for that. We're going to talk about this. We definitely going to talk a little bit about acupuncture as a supportive treatment, and that's actually going to be my next question for you. But then we do a lot of this optimization. We use different metabolic approaches, and so we can talk a little bit about all of this. We're not going to have even close time to talk about all of this. There's this whole controversy of medical cannabis for cancer. We even recorded several podcasts on this topic. One was with Donald Abrams a long time ago, and then several others, at least one other that I remember, probably two more. So we can talk a little bit about that if we have time. And so we also have a little bit of resources here. We do have a couple of different senior leaders in the field that we're working closely with. Wayne Jonas is a great example. His recent book is also listed here. So, Dr. Orceyre, let's talk a little bit about supportive care first, because this is so important. You mentioned it early. We want to not just have people go through the chemo, radiation, and surgery and then be completely debilitated with side effects. We know that one of the probably most important reasons why people do great in our program is because we prepare them for the aggressiveness of treatment. We minimize their side effects. We get them ready for what's coming. We make them feel better during the treatment. And actually, probably that's why, at least in part, they do so much better because they can tolerate the treatment. The part of the problem,
Exactly.
a lot of patients just have to drop out of the treatment halfway through. And so, of course, you're going to have a worse response. In our program, our tools tend to really help the patient. So let's talk about first, you're an expert in acupuncture, particularly in oncologic acupuncture. Let's talk about this, right? There's lots and lots of evidence of use of acupuncture in oncology. I mean, there are probably more studies than for any specific chemotherapeutic drug, I presume, literally, because
Yeah.
China, is every patient in China gets acupuncture when they get cancer? Pretty much, right?
Not necessarily, no, but they have access to it and they can go every day for free or minimal cost.
Every day.
Every day,
Yeah.
every day.
The
And the acupuncture is in the hospital.
in a hospital, right? It's in their center in the places where they actually get all other oncology treatments. So it's simplified for them. So what are you observing? I mean, when patients kind of sign into your program and you also do acupuncture for them, what have they
Yeah.
told you?
Well, if there's one thing that patients can do when they have a cancer diagnosis and they're embarking on the treatment journey, the conventional treatment journey is acupuncture. There's so much research on acupuncture for pretty much all the side effects of conventional treatment, whether it's surgical recovery, fatigue from radiation, chemo-induced nausea and vomiting, chemo-induced neuropathy, peripheral neuropathy, just general fatigue, sleep, emotional ups and downs that everyone goes through. All of these there's a lot of evidence. And also, I see it daily with my patients that it's really ameliorated by acupuncture treatment. And when I say acupuncture, we sometimes also add in other treatments like moxa. I do qigong visualizations with people. We have a biomat on the table. So it's a pretty nice, relaxed time for those patients, and it can be a kind of an oasis amidst all the chaos and the difficulty of cancer diagnosis and treatment.
It's truly a whole body treatment. It
Yeah,
doesn't just say, oh, you got nausea here, let's put needles for nausea, right? So
right.
the idea is, the cancer and cancer treatment is the whole body experience, right? It's a massive energetic change. It's a massive shift in metabolism of the structure. And I think acupuncture has this very low side effect profile, very powerful way of optimizing this. And I want to just briefly comment on the research. I mean, it's not all research from China. We now have multiple large controlled trials from the US. I
Yeah.
mentioned Sloan, and one of our good friend, Jun Mao, who's the head of the program there. He's done probably, I mean, I don't know, half a dozen of controlled trials on not just side effects, but also even some adjunct outcomes showing some benefits. So we know that acupuncture is powerful. We know that it's not only improving the quality of care of patients and the quality of their life, but it actually improves outcomes to some extent. And it's sometimes hard for the conventional realm to swallow this because, it's not like the cancer getting wiped out by a needle put into it, right? It's completely different approach, but it shows you the sort of this value of treating the person instead of the disease. And it's kind of the probably most evidenced integrative approach we have. So thank you for covering that. I mean, there's a
Mhm.
lot of other things supportive listed. I don't think we want to go into them. I think all of them have a lot less research, but I will ask you about lifestyle. Particularly the diet, the exercise, the mindfulness. I mean, I think we incorporate in care
Mhm.
all of our oncology patients, but just spend a couple of minutes kind of
Mhm.
talking about how do you discuss this, how do you advocate for it, and
Yeah.
you know.
W well, I mean, if exercise was a drug, it would be a billion-dollar profit drug.
Yep.
There's so much good evidence about cancer and exercise, and, the more they do, the more we understand, and basically it helps prevent recurrence, it helps people recover from treatment, and it's, you know, um, 20 to 30 minutes a day of moderate level exercise where moderate level cardio is enough, like for example, for breast cancer patients who are post treatment to strongly reduce the risk of recurrence. It's dramatic. Like no drug has that. And so I always talk with patients about movement and exercise, but some people overdo it actually. So we have to always watch when they're getting treatment. That's not the time to suddenly ramp up your cardio. Um, and then, of course, there's exercise for preventing the long-term side effects of treatment, like bone loss from losing estrogen and so forth. But that's sort of another topic. And then with diet, this is a very controversial topic, and we could spend an entire hour just talking
Right.
about diets for cancer, and I'm happy to do that another time. For today, I will say that if we're just talking about evidence, we know that eating in such a way that people maintain a healthy body weight, a healthy body composition, also reduces risk, particularly for people that are overweight or obese at diagnosis. If they can get down to their healthy body weight or their healthy body composition after treatment, it dramatically reduces the risk of recurrence. So that's well evidenced. And then also another dietary intervention that's well evidenced is fasting around chemotherapy, which is
Mhm.
controversial with the oncology team and the nurses, but there is really good evidence. And so that's something I talk with my patients about if they're interested, but certainly not everyone wants to take that on and they don't have to. So those are some of the things that we discuss. And then also, of course, sleep and rest is critical. And when someone's getting an aggressive cancer treatment, it's not a failure to need more rest. It's listening to your body and actually giving it what it needs. And even though someone who's very alive and active, in their daily life may feel it's a failure to need to sleep more and cut out activities, I actually see it as a very good thing. It's not good to try to keep up when you have to listen to your body. So anyway, we talk about those things. Did you have anything else in mind that you were thinking about?
Well, I just want to add a little bit about the diet and, particularly this whole idea of ketosis comes up all the time
Oh,
and,
yeah, ketogenic
and
diet.
ketogenic
Yeah.
diet. So we're not actually strict ketogenic at our clinic. We give people a lot more freedom, but I think there is some wisdom in, cutting down sugar and carbs to absolute minimum,
Yeah.
given some of the research.
Yeah.
There's good amount of evidence that what we
Yeah.
sometimes call cancer is metabolic disease. And the
Yeah,
other
absolutely.
and the other thing is, people always add, we always talk about intermittent fasting, but we also talk about fast mimicking diet, which is the prolonged, it's Walter Longo's invention of, instead of saying, look, you just fast, you do 5-day, very high quality vegetarian ketogenic smaller amount of calories, so you end up in pretty deep ketosis by the day 3 to 5. And so they would try to, there's a lot of research actually, there's multiple studies now, particularly specifically breast cancer's positive studies showing that if a woman is taking the prolone and then doing the treatment right in the middle of the prolone or towards the end, like day 3 to 5, the outcomes are better. So this is what Dr. Orceyre is mentioning, and we will work with each individual patient to kind of fit this specifically for them. Whether it's a fasting could be perceived as a little bit more natural in a way than some highly processed complex diet, but still the data is there, so we will follow the data.
Yeah. And it's very individual, it's not necessarily right for every patient. And I've seen patients who make themselves crazy trying to do extreme diets. And I actually think it's counterproductive. So sometimes we have to deal with that, but yeah.
So let's move towards more things that you really wanted to talk about today, which is some of the kind of a more disease-modifying treatments, right? So I mentioned particularly the mistletoe and intravenous vitamin C. Again, we're not going to talk about cannabis. There is not enough evidence that cannabis has a significant disease-modifying effects, although I do believe that that's the case. I just have to acknowledge the fact that evidence is very limited. We only have evidence for brain tumors of a couple of different types, and the evidence is quite small. So I don't think that we should go there. But we do have the program, and so anyone interested in using cannabinoids for symptom, but also for disease modification, we can offer that. One of our cannabis coaches, Dr. Benavides, is actually quite experienced, and also I sometimes would see patients for that. But let's start with the vitamin C. And the only reason I want us to start vitamin C is only because we've done it a lot longer. I mean, we've been doing vitamin C for what? And
25 years.
yeah, I
Like
think John Pan, who founded our clinic, I think he started before we came, right?
Yeah, it was definitely going when I was here. Barbara was doing it.
Yeah, so Barbara was doing it for cancer. So this was probably going back to, probably close to 25 years by now.
Yeah,
You know,
I think so.
I think in 2009, I want to say, or maybe 10, we actually did an internal assessment. We looked back into several years of our vitamin C data. We never got that published because the student who was doing this was a wonderful student. She went to the osteopathic school, but we did present it at a conference, at a large conference. So, and we've seen some really interesting data. Subsequently, we had some cases we published. So we had several cases. We published some cases that were presented at the conference and were published as an abstract. I think we also have one publication on use of that in one of the journals. So you've been overseeing thousands of patients who's getting intravenous vitamin C. Let's talk about this. Why, why vitamin C? Like, why can't people take it orally? Why do they have
Oh,
to
yeah.
spend,
Right.
thousands of dollars on intravenous?
Right. So everybody knows about vitamin C and Linus Pauling, who popularized vitamin C. And most people know that vitamin C is an antioxidant. But what most people don't realize is that when we take it orally, we can only absorb a maximum amount in a certain period of time. And so we can never truly, I'll use the word perfuse, all of our tissues when we take it orally. So we can never get our blood level high enough with oral administration to get the vitamin C throughout all of the tissues in our body.
At
So
high enough level,
at high enough
because
levels,
we
right?
need that. Mhm.
Right. And so what we do at the clinic is we use intravenous vitamin C in order to get the levels high enough to create the effect we want. Now, what is that effect? So, as I mentioned, most people know that vitamin C is an antioxidant, but at high levels, vitamin C actually turns into a pro-oxidant. And that's the opposite of what it does at low levels. So when it's a pro-oxidant, it goes into the tissues and it turns into hydrogen peroxide, believe it or not, at the tissue level. And then what happens is that the normal tissue is like, oh, some hydrogen peroxide, no big deal. But the cancer tissue cannot breathe. It cannot grow when it's surrounded in a hydrogen peroxide environment. And so it essentially starves or suffocates the cancer cells. And the vitamin C itself only lives in the body, we pee it out and it's gone after, say, 24 hours. So people have to come back every week at least. And some of our patients, usually patients who have more advanced cancers, will come twice, and some even come 3 times a week to try to get this effect in a more sustained way.
And there's some strong advocates from some of our friends and from the leaders of this field, including Mark Levine at NIH, who's done the most research, and he's a close friend of a clinic. Mark is after very strong opinion that we should really be doing it almost daily, but I mean,
Yeah.
it's just not, unfortunately,
It's too expensive. It's
practical.
hard
It's
for
too
people to get down
expensive.
here.
I
Yeah,
mean, you can't spend 2 hours every day getting an infusion.
right,
It's just you
right.
you need to have life. So
Yeah.
there's limits.
It's the same for acupuncture. It's like we should be doing it daily. Yeah.
But
Mhm.
think about this. But we can dream. We can dream. We can dream and say, look, well, why not? I mean, people spend hundreds of thousands of dollars on a cancer treatment. I mean, here we're talking about few $1,000s. I mean, in comparison to cost of chemoradiation and all of that, we're talking about pennies to a dollar. And why can't we have, continuous model where people can get they can get daily acupuncture, they can get mistletoe instead of once a week,
I
2
know.
3 times a week. I mean, we can do all of this as a packaged care and then build to the insurance. And in fact, I believe, here's just I'm gonna go crazy here. I do believe that no matter how the resistant the oncology is, I think over time we'll collect enough data and we'll go to some of the insurance and say, hey, instead of sending patient to yet another round of chemo, send them to us. The outcome's probably going to be just as good because we're not substituting. We're just basically not necessarily running through multiple sources of chemotherapy. We're simply starting in combination so the patients respond better. They don't need more treatment. And that more treatment, that's where the saving comes from.
Yeah.
So yeah, you and I both seen a lot of interesting cases with vitamin C. Care to give us a little bit of an examples, or what you typically
Oh, the
observing?
ones that stick in my mind actually, well, I have a few patients right now who have either had very aggressive disease. So, like the ones I'm thinking of, a colorectal patient, an ovarian patient, a couple of ovarian cancer patients, actually, and a colorectal cancer patient. That's just right now, who were really, everyone thought they were at the end of their life,
Mhm,
and then they added in the vitamin C into their regimen along with whatever their chemo protocol was, maybe a platinum drug for the ovarian, or maybe a 5-FU drug, or a Xeloda type drug for the colorectal that was like on a daily basis. And then suddenly they're stable. And then the disease might even still be there, but it's not doing anything. It's not getting any worse.
mhm,
And I have a couple of patients right now who have no evidence of disease. And one of them is an ovarian cancer patient who's on a PARP inhibitor, which is a sort of a newer class of treatment. And the other one is colorectal. And I don't even think she takes Xeloda anymore, but she did for years. And they're both just cruising along, and they come in. And right now, I think they used to come at least weekly, maybe multiple times a week. And now they come much less than that, maybe once a month. Excuse me.
mhm. Yeah, I mean, we have a
Yeah.
whole list of patients who've been with us now for some patients for over a decade, and they're coming in on a kind of a more of a, I guess, long-term care now, right? I mean,
Yeah.
we have
It's management of cancer as a chronic disease
that's it.
instead of, a life-threatening illness.
And also managing it in the situations where the traditional oncology has nothing to offer at that point, right? I mean,
Right.
once the patient finished And they said, well, you're stable now. You're just going to run CAT scans once a year with a lot of radiation, but that's a whole separate conversation.
Yeah.
Anyway, but then there's nothing happening there. It's just an observation. And so our tool, particularly the one, the vitamin C, there's simply because we've had so much history with it over the years.
Mhm, mhm.
So yeah, and I've seen cases too. Like I particularly remember this case we presented at one of our conferences of a pretty old woman with chronic leukemia, and she came to us. Basically, oncologist says, "We're done. I can offer you another chemo." She said, "Absolutely not. That last one made me so sick." And he said, "Okay, then let's go to hospice." So she came to us, and she lasted for more than 5 years, and she
Mhm.
completely stabilized. She died in her late 80s. And I think partially she just also getting a bit older, and chemotherapy took quite a toll. So sometimes we end up seeing this scenario play out over a prolonged period of time, but the quality of life that we gave her was quite good. So
Yeah.
I want you to go back to that moment for a second. We're seeing a lot of patients get better quality of life pretty quickly with our treatments. And I kind of mentioned it. I think it does translate to the better long-term outcomes. But I also think it's often a primary goal for us. We know we're not necessarily in the business of curing every patient with cancer. That's sort of the oncologist's job, I feel almost. But we are in a job of saying, if you come to us, expect that you're going to feel better. Expect that we will make you to feel better, not only so you can tolerate the chemo, but that's just what we do. I mean, this is part of the core concept of integrative medicine. Treat the whole person, don't treat just a disease. As you do that, the quality of life improves. Do you have anything to add to this?
Well, when you say that, actually, it makes me think about how we, in addition to supporting the oncology treatment and trying to boost the cancer killing effects and all of that, we also look at the rest, like you said, the rest of the body, the terrain of the body. And we are often adding in assessments of people's digestion, their microbiome, their nutritional status, making sure they aren't depleted of their macro or micronutrients, talking about their relationships and their support and their community. And I have had more than one patient who was in a very unhappy situation, and leaving that situation contributed to their long-term health, I believe, making those kind of changes. And actually, there's a book that I love to recommend to patients called Radical Remission by Kelly Turner, where she lists out, based on research, the different things that people do in their treatment after a cancer diagnosis that they have in common with other people who have had radical remissions, where the cancer disappears when no one thinks it would have. So we do a lot of that. You made me think of that when you were
For
talking.
all the listeners, don't worry about memorizing this. We'll make sure we put all the links in the description.
Yeah,
You can just check out, and we'll put all the resources, including link to our
yeah,
program, Dr. Orceyre's bio, and the books.
yeah. And so I wanted to also add one thing about the vitamin C treatment, because when I have a patient in the office, they often ask me about this.
Mhm.
So the treatments are pretty benign. They're just an IV. Usually they last like an hour and a half, 2 hours at the most. And people come in about once a week. Depending on how much vitamin C patients are given, the cost will vary. It's usually somewhere around the 350 to 450 range. Although don't hold us to that based on the new tariffs and all of that. Who knows what will happen? And we have to do a lab test before patients can start the IVs. So they have to have a visit with a practitioner, and we have to order a lab called G6PD, which is glucose 6 phosphate dehydrogenase. It's a mouthful.
I can't,
That,
be- I can't believe you just said it without.
oh, yeah, well, I say it all the time.
I don't
and
try.
and that enzyme is a very rare, some people genetically have a deficiency of that enzyme, and when someone is deficient in that enzyme, we either don't do the vitamin C, or we have to do lower doses, monitor more carefully, for example. um, And so there are things that have to be done to prepare. We have to make sure that somebody's not too anemic or that they don't have kidney problems, that kind of stuff, to do it safely. So those are all things to expect when you come in to get treatment with vitamin C IV. I just wanted to mention that because it's a practical concern that people have.
Right. So, and also a lot of the times, what comes up is, once we start bringing up this more disease-modifying treatments with the patient's oncologist, sometimes we run into some tension. So we do have to acknowledge that it's not so straightforward. Some oncologists refuse. There's also have been some data that you have to be a little careful of combining C at the same time with a chemo. So we do have to acknowledge this. And the reason for that is, as we pointed out, right, the vitamin C can be both pro-oxidant, but also an antioxidant. So at the tail end of the infusion, there's some antioxidant impact. And then there's maybe anyway, so there's a lot of controversy here. So we often basically play it one-on-one with each case. We talk to the oncology team. If they're really strongly opposing, of course, we're going to say that's fine, just finish your chemo and then come in and we'll start right after when the chemo is done. So we do all of that. And then let's talk about mistletoe. We left it for the last, I think mostly because of the evidence and I think also because of what we're observing, right? And so, of course, everybody who is interested in this topic have seen the Johns Hopkins study back from nowadays, and I don't know, 3 years ago. I can't even remember. Time just flies, huh?
Maybe more than that, yeah.
Maybe more, maybe
Was
less.
it during the pandemic?
Oh yeah, no, the results came out during pandemic because they
Okay.
started the trial before, but then they published it during. Of course, we already reviewed the study. The study had a profound benefit. It was recruiting only very advanced disease cases, and with those cases, there's significant improved longevity, quality of life was dramatically improved. So there's a really strong effect. Of course, nothing followed. The study was out there. It was the Hopkins. It was one of the lead oncologists at Johns Hopkins who was the PI, who we know very well. We tried to send patients. Nothing changed politically, right? I mean, we're not hearing any movement insurances to pick up a slack and paying for it. Anyway, so I had to put in a political, I also do have to put political disclaimer because I was on the NCI board of advisors for alternative integrative medicine.
NCI being National Cancer
Institute, and as you know, but listeners may not, is that the new administration shut us down. They basically said this is not interesting, which I found crazy because I felt like the new administration is interested in.
So this is a branch of NIH.
Yeah, it's a branch of NIH, and we were basically compiling all the data on integrative whole person care for cancer patients. I was one of many top experts there, and we got shut down. We used to have 3 or 4 meetings a year in person, or some were virtual for half a day, so we can review all the recent literature, vote on what gets included into compendium available for everybody, looking to discuss the studies and analyze everything. And now general public will not have this information going forward. Whatever's in there gonna stay on the website, and I'll make sure I'll put the link for it. But beyond that, it's not gonna be updated. But anyway, it's sad, but it's true. So, but we're seeing an amazing results with mistletoe too. So tell us a little bit about mistletoe. Works very different. So let's start with what is mistletoe and how does it?
Yeah. So mistletoe obviously is a plant, and the Latin name is Viscum album. And when we all know mistletoe at Christmas time, you kiss under the mistletoe, it has red berries. Well, this mistletoe is European mistletoe, same plant, but slightly different variety. And it has white berries. That's why it's called album, Viscum album, like white. And I learned about mistletoe actually in my herbal training because as a naturopathic physician, I am a trained herbalist. And so we studied mistletoe viscum as a toxic herb. But without going into too much extensive detail, there was, many of you may have heard of Rudolf Steiner. And so historically, mistletoe was used as a toxic herb. But then Rudolf Steiner really popularized using mistletoe for cancer. And he began by extracting the mistletoe and injecting it under the skin, which is called a subcutaneous injection, very tiny needle.
Mhm.
And what that would do is it would stimulate the immune system to react. and it's actually, in fancy terms, it's called the dendritic immunity. And the dendritic immunity then goes on to activate many different arms of our immune system.
Mhm.
And in what we see, for example, in blood work after people are given a mistletoe injection, is that various cells and chemicals are increased. For example, natural killer cells. Also, there are these things called cytokines that are really like soldiers in our immune system's army,
Mhm.
and they attack and they can cause the redness and some of the swelling that may happen around a mistletoe injection. And so that is really how mistletoe works. It activates the immune system and it activates all the players that then attack cancer cells. And there's tons and tons of research right now on immunotherapy and all kinds of different drugs that are using the immune system to attack the cancer. And mistletoe is kind of an early immunotherapy in a way where it's boosting the different types of fighters in our immune system. So mistletoe grows on trees. It's a parasitic plant, and it grows on three types of tree. Well, more than that, but the ones that we use, there are three different types. One that grows on the fir tree, also called abiatus, which is the Latin for fir tree, the pine tree or pini, and the apple tree or molly. And each one of these types of mistletoe has a slightly different profile. So we might use one of them, like we might use molly for a postmenopausal breast cancer patient, but we might use peony for a premenopausal breast cancer patient. We might use abiatus for a brain cancer patient. So there's different uses for these different, and they have slightly different, as I said, profiles. One of them might be a little stronger, one of them might be a bit more weaker or less aggressive, etc. So that's what mistletoe is. And then before I dive off onto how we administer it, maybe you want to say anything.
Well, yeah. So I mean, I think I definitely want to make sure that the review, we have a YouTube video on review of the study. I think the study really changed the field, and we've been having lots of requests for
Oh,
this therapy since the
yeah.
study came out. But we kind of seen this before. I mean, we started using mistletoe years before the study got published. Actually, even years before the study was started.
Yeah.
So we've observed some of these benefits for a long time. We also do combine mistletoe with vitamin C, and I think it's important you talk a little bit about that, but we're seeing definitely synergistic effect. If you combine safe treatments that are well tolerated and you combine them in different mechanism of action, there's generally quite substantial synergism that occur. And definitely between vitamin C and mistletoe, there's a substantial synergism. One becomes kind of the antioxidant and pro-oxidant, sorry, and kind of directly kills these tumor cells from literally, as you called it, suffocated. I just describe it a little bit more like just a free radical burst, literally directly kills the cell. And then the mistletoe is optimizing immunity, boosts inflammation, boosts immune response, and clears the cancer that way. So let's talk a little bit about the issue with mistletoe is it's very complicated. Not every practice can do this for two reasons. Well, one is, as you mentioned, there's a bunch of different types, and you have to know which cancer. You have to get very specialized training. You have to prescribe it precisely. You have to observe, and also there are more side effects. Right? With vitamin C, there's almost no side effects. I would say occasional allergies, occasionally if the needle pokes through the vein, you can have a lot of pain and swelling localized, but those are all non-systemic localized side effects. But with mistletoe, we have seen occasional side effects, high blood pressure, kind of the very severe flu-like reactions, which are actually what we're looking for. We're looking for that immune boosting effect. But what have you observed in terms of like overall response and tolerability of mistletoe?
Mhm. It's across the board. And people have very different responses to dosing. I have some patients that have to do a zero point 0.1 milligram and they get a very strong reaction. I have some patients that do 100 milligrams and they don't get any reaction. So it's very individualized. But what you're looking for when we do it subcutaneously, I'm talking about, although IV has sort of a similar profile. So we do it both subcutaneously and intravenous in the clinic. But initially with subcutaneous, we're looking for a little red welt, that is, a size of a quarter or less, that might itch. It might be swollen, kind of like a hive, or what might happen to some people after a bee sting. And then some people get a very slight temperature bump, like they get a 99, or they feel a little bit achy or fluish for about 24 hours. And that's great. All of those things indicate a nice response, and we know, okay, this is a good dose.
Mhm.
If we overdo it, patients will get sort of the extreme version of those things. They might
Mhm.
get a bigger welt that lasts longer and is really itchy or even a little painful. They might get a higher fever. They might feel, like you mentioned, the fluish reaction. And so then we know we've overshot the dosing and we have to drop it down. There's no, it goes away after a few days. It's just unpleasant and uncomfortable. With subcutaneous, I've never had anyone have an allergic reaction. I've never had anyone that had to go to the hospital or anything like that. But I have had people that were like, "Whoa, that's a little too intense for me," and so it's not an appropriate treatment for that person. Most people, no big deal at all. The hardest part for most people is learning how to do the subcutaneous injection. But we do a training. People come in, they get a training, and we have lots of help, and we check in about it.
And
So
subcutaneous makes it quite affordable. That's actually the
yeah,
one of the biggest draws why people would want to do this, is because unfortunately doing anything intravenous, yes, it's much more effective. But again, this is all out-of-pocket costs. They add up very quickly. Subcutaneous is a lot cheaper. You can do this yourself at home. You're just buying the actual supplies and the mistletoe itself in the vials, and it's actually can be pretty cost effective.
yeah. It's a tiny little needle, and it's really not hard. But some people do have a needle phobia, a true phobia, and they can't do it. But most people, it's just fine. And then we have our IV mistletoe program, and this one, it's more expensive to come in and get an IV of mistletoe. So I don't recommend it for everyone. It's kind of on a case by case, depending on how advanced the cancer is, depending on the resources of the patient, the time they have, their financial resources, et cetera. But it does something similar, but it doesn't do it through that dendritic immunity that I mentioned. It does it directly, and there's no proof of this in any clinical trials that I know of. But the idea is that when we do it IV, it also travels through the tissue to the cancer and directly destroys the cancer. So when we do it subcutaneously, it's like it pushes the immune system to do that. But when we do it IV, the hope is that it will push the immune system, but it will also go directly to the cancer.
I just realized, do we know the mechanism of action in there specifically, like what happens, or is it still
Well,
the immune system?
I don't think we do. And that's really, I think, because most of the mechanistic studies are still preclinical. So um, we have lots, as you know, we have lots of clinical studies with mistletoe showing that it's beneficial for quality of life. We
Mhm.
have a recent study showing that it does not cause any interactions with certain immunotherapies.
Mhm.
So there's lots of, it doesn't cause any bad side effects. We know all of that from clinical trials. But really, unless I'm missing something, we just know that it increases those immune chemicals in the body, the immune.
That's what I thought. I have not
Yeah.
seen, but I mean, we definitely know that the IV seems to be more effective. I mean, I don't think there's any true discussion about that. It's just the cost and complexity of that, and the fact that very few places offer that, I think makes it basically impractical for most cancer.
Well, I'm going to push back on that a little bit, because the way I was trained is that they're actually different. And the dendritic immunity is an important piece that you
Mhm.
can only get from the subcutaneous injection.
Mm.
So I think even when my patients are getting IV, I still have
Right.
them do
So,
sub.
so this is this the reason why we do both then?
Yeah, that's why I recommend
We
both.
push everybody to do both, right? We start with sub-Q, assuming they're tolerating it well, then we move them over to the IV again,
Yeah,
all things practically possible, like
yeah,
cost and
yeah.
logistics of being
Yeah,
there.
and I'll have people come in maybe once a week or twice a week for an IV, and then whatever, then either they'll do 1 or 2 subcutaneous injections on opposite days, so that they end up with 3 mistletoe treatments a week. That's how I do it, what I
Great.
recommend.
Well, we're getting close on time, and I think I want to give you last couple of minutes just to add anything. Maybe we forgot. I know we forgot to talk about your collaboration with George Washington University. You've been part of the breast cancer team with Dr. Christine Teal for quite a while. In fact, our clinic is listed in Dr. Teal's book. I think the book is called No Longer Radical, I believe. Is it? I think so. It's a new book about the breast cancer. I'll make sure to put the link in there in the description for the book as well. So anything you want to add to kind of in closing?
Well, I really hope that this is helpful for patients and just general people who are watching. I know that folks have a lot of questions, and it will be good to be able to get these questions answered before a visit, or, help deepen your understanding of what we do and why. And I also want to say that we're talking about a lot of treatments, a lot of research, and that it's also very important to us at the GW Center for Integrative Medicine to work as a team with our patients and to support you, to support the patient and listen to what your needs are and what you want, and not, just tell you what to do or talk down to you or try to twist your arm to do something or try to, get you to do something you're not comfortable with. Like we never want that. We really believe in patient empowerment and maintaining a strong relationship of trust with our patients and letting you lead the way in a lot of senses. So just to end with that, because I think that's one of the most important things that we do. And we've been doing the mistletoe and the vitamin C and the integrative oncology for a long time now. And I think our patients really benefit from it. So yeah, thank you for this opportunity.
Well, we spent a lot more time than I thought we would, which of course expected when we start talking. There's always something to talk.
Yeah,
Yeah.
lots to discuss.
But do subscribe to the YouTube channel. It helps the channel. It helps you. And if you have specific interest in kind of cancer as a broader topic, as I mentioned, we did talk about a little bit about a cancer, cannabis for cancer. Now we have this more. We had a conversation with Dr. Sodral Sadot a couple of maybe a year ago or so. So we had some are different, but we can always go into specifics on any particular sub-treatment. Each piece in integrative oncology treatment can probably take many hours on its own. So we understand that we very superficially touched up on things, but hopefully this will be helpful for everybody. Have a
Oh, and
wonderful.
if
Yeah.
you have any topics that you wish we had talked more about today or that you want to hear about, please put it in the do you have an open chat?
Yeah, well, it's the people will comment on YouTube video,
Yeah,
and I
comments. That's what
check.
I
Yeah,
meant.
I
Yeah.
check the videos. I check the comments with some
Oh,
regularity.
good. So we have open comments. So go ahead and
Yeah,
put in the
yeah.
comments, and if there's something that a lot of people want to hear about, maybe we'll do this
Oh
again.
yeah, we'll do a second. Yeah, absolutely. And we can also do them. We're also going to do some more specific targeted presentation as some other stuff comes up as we have new research and things like this. So I hope everybody's doing well. Stay in touch. Please, as I said, subscribe to the channel if you don't want to miss anything. Have a wonderful day, and we'll see you back here. Thank you so much.
Bye-bye.